I
We'll figure
started
it out.
recording right now. Yeah.
We'll figure it out.
Thank you so much, everybody, for joining us for one of our last sessions over Road to the PSA. It's nice to see you all again and Happy New Year. Very, very happy to be welcoming my good friend Abdullah to join us. Abdullah and I started teaching MedEd back in 2022, 2023, back when we were getting 7 attendees, and now we sometimes get up to 70. So it's so nice to have you all. Abdullah's the best. He's also not tuning in from the UK. So thank you for staying up very late to teach this session. And yeah, over to you, Abdullah. I'll be answering people's questions, logistics stuff in the chat. Pop any questions in there. And yeah, enjoy the session. It might be a longer one tonight because it's a big summary, but exams come in, so sacrifices must be made.
Absolutely.
Go ahead.
Okay, thank you for the introduction. My name's Abdullah. Graduated Manchester, and I'm an F1. Well, we call it intern here in Kuwait. Yeah, glad to be doing this teaching session with you guys today. Am I going to be able to see the answers? Just can you not if
You should be able to, but if not, I will read them out to you.
perfect. Okay, so here's hopefully there's nothing you're not expecting. So this is like the outline of the different specialties and the different skills you'll be tested on the PSA. This table, again, you can look through it, the table and the slides, but there's sort of like different conditions and different medications to look through for each specialty and each skill. So I'd highly recommend you taking the time, just quick look through each specialty and just practice any skills and any specific conditions you're not sure how to look up on the BNF just before your exam. Okay, so a lot of this is going to be questions. So I'll be asking a lot of questions, and it'd be very great if you can contribute with answers in the chat function. And we'll be having a few tips, just recap points from the previous sessions, the different sessions you've had. And we'll kick things off with drug calculations, start off simple and pick up as we go. So very, very simple. How many mils of 1 to 1000 atropine are needed for a 0.5 milligram dose? I'm hoping I will be able to see the answers. Let me know if the answers start coming through.
We've got nothing yet. A lot of the time we get people kind of write down their answers and then they like the message to say that they've done it. So if people want to show that they're engaging with the session by just liking my previous message, that would be great, guys. Just so we know you're all alive. Yeah, so you've already got 4 people, 5. Yeah, it's going up pretty rapidly. And someone has answered saying half a mil. So everybody's here. You've got 12 people that have liked the message to say they've answered it too. So yeah, 0.5 mils is the answer someone's given.
2 takeaway points. The first is what the ratio means. So 1 in 1000 is basically a gram in 1000 milliliters. So that's very important to just to hone down. And every time you see a question similar to that, that's the first thing you want to think about. What does the ratio mean? You want to put that into context. The second thing is, and this is something you'll need with most of the calculations, the unit conversion. So a kilogram, a gram, a milligram, and a microgram. So times 1000 to the right and divide as you would expect because it gets smaller as the quantity gets bigger. Okay, a bit of a longer question here. Another calculation. I'll give you guys a minute. Is it a minute or just over a minute? Like the
2 minutes, I think.
Okay, we'll do a minute and a half, just to add pressure. A minute and a half.
Gonna pop a message in the chat, guys, so people can like it when they're done.
Okay, 32-year-old man presenting to the emergency department with a suspected heroin overdose, received naloxone 800 micrograms IV, regained consciousness 15 minutes, but then became drowsy again. Now requires naloxone hydrochloride to be administered IV at a rate that says that will give 60% of the initial resuscitative IV dose per hour. And then it asks, it says an infusion containing naloxone hydrochloride 2 milligrams is made up to 500 milliliters with glucose 5%, and it asks you to calculate the volume needed per hour using information given. So the things you need to, the steps you need to reach the answer is to calculate what the dose needed. So you'll multiply 0.6 or 60 over 100 by 800 micrograms, and then you'll need to convert that using the solution that's available, which it said in the question was 2 milligrams of naloxone hydrochloride. So by multiplying the fraction of 480 micrograms by 4, hopefully you'll get to 120 milliliters. So it's the same principle of the ratio and converting to get to the solution, and then multiplying that by the dose you need, which it said was 60% of the initial response. So second question, similar again here. They want you to calculate the volume desmopressin solution for injection. So I'll give you another minute and a half, and then we'll go through the answer.
Just for reference, you've got 13 people already finished, but I don't know how much is left on the time.
10-year-old boy, Van Willebrands, 32 kilograms, requires an IV solution of desmopressin prior to surgery. The solution concentration available is 300 nanograms, so that's very important to point out the units per kilogram IV over 20 minutes. It has been diluted to 50 mils solution, and the available supply of desmopressin is 1 milliliter containing 4 micrograms per milliliter. So an extra step at the start is the unit conversion. You can do it at the start or whenever you like, but it's very important to keep the units consistent, whether that's nanograms or micrograms. You'll calculate the dose by weight. So you multiply 300 by 32 kilograms, and then you'll convert the answer back into micrograms. So that'll be dividing 1,000. So moving to the left, if you remember the flow chart I showed at the start, to get to the concentration, and then you use the concentration and the solution available to get to the volume. So that's the weight by the volume. If you multiply and divide the ratio, 9.6 by 4 micrograms should get you to 2.4. Okay, so we'll move on from just general drug calculations to opioid conversion. So this forms an important part of drug calculations in the exam. And this is just an example question. A patient currently takes morphine, 13 milligrams, orally twice daily. The decision has been made to switch them to oral oxycodone. So converting morphine, 30 milligrams twice daily, very important, to oral oxycodone. So BNF's out, and I think it's like a hopefully one-step calculation should get you to the total daily dose of oxycodone. We'll say a minute for this one, a minute. It's just practicing reaching the table with the conversions, the different factor conversions on the BNF. Cool. So 30 milligrams total daily dose. So if you look at the conversion factor, should be one half, should be 0.5. So morphine total daily dose would be 60 milligrams, and to convert that to oxycodone would be to divide by 2. So 30 milligrams for that for oxycodone. So to get to the table I was talking about, this is how. Obviously, I don't have access to it now because I'm not in the UK. But you go to medicines guidance, and then prescribing palliative care. That's where the tables are. And then this is what I'm talking about. So equivalent doses of opioid analgesics to oral morphine. And then you've also got for the same administration, converting to different formats or different opioids. Yeah. Okay, another opioid question. This time it's not conversion, it's adjustment. So adjusting morphine two different ways, but we'll go through that in just a second. So as patient E takes 20 milligrams modified release morphine twice daily, and they're also prescribed 5 milligrams immediate release morphine as breakthrough pain 4 times daily. But their pain is not controlled. So how would you change this patient's morphine prescription to better control the pain? Yeah, we'll go through the principle in just a second, but have a go at this question. We'll say like a minute for this one. Huh? Okay, so 20 milligrams modified release twice daily. So the trick in this question, well, the only thing you need to know really is you don't touch the breakthrough. You modify whatever dose they're having besides the breakthrough point. So their as needed prescription, if you like. So that gets changed. We'll go through, yeah, those are the 2 points that I wanted to talk about in terms of opioid adjustments. So the first thing you need to know is that when you're increasing a patient's morphine dose, so patients are taking morphine still complaining of pain, you do not increase more than 30%. So it depends on what dose they were taking in the question, what the question says, and then whatever you have available, you'll just have to tweak, but to make sure it's not more than 30% of their overall daily morphine dose. And the second point for breakthrough pain is that the increase, that the dose that they're taking for the breakthrough pain, it should be between a tenth and a sixth of the total overall morphine dose that they're taking daily. Is this a fluids question? Yeah. Okay, this is another IV fluids question. Again, if you like, that's the third category of questions that you can get from drug calculations. So we went through a few calculations. We talked about opioid conversion and adjustment, and then fluids will also be an important part. So have a go at this question. It's a bit of a long one, so we'll say a minute, and then we'll go through it together.
Just got a couple of questions in the chat, Abdullah. First one is people are struggling to understand whether morphine is given through the oral, subcut, or IV route, if not stated. For example, this one said modified release. I just said if it says modified release, that tends to suggest per oral, just because I think only tablets can actually be modified release, because otherwise you're giving things directly into the system. You can't modify how quickly that'll be absorbed slash metabolized. And then two people have asked if you could go through the previous question again. So I think if we finish this one and then go back through the last one, that should work.
Yeah.
Fab. Oh, thank you very much, Paul. I will edit that now.
Okay, so 26-year-old email presents to emergency department, drowsy and irritable and unresponsive, has a history of type 1 diabetes, so that gives you a clue on what's going on. She's taken insulin doses and metformin as well. Glucagon has already been administered 15 minutes ago. On examination, unresponsive and clammy, tachy, with a normal blood pressure. You've got a few labs, which most of which appear normal. Random complete glucose is 3, was 2.8, so it's improved a bit. And their ketones are normal. ABG shows a low CO2 acidic picture with metabolic acidosis and a bit of bicarb compensation, and it asks you to prescribe 1 IV fluid to help with her symptoms. So hopefully you've spotted that she's hypoglycemic, but out of the way. So we've got 2 different solutions can be prescribed as per ENF, the guidelines. That's what tells you what to prescribe. So infusions of 10% or 20%, 150 to 200 in 10, and 75 to 100 in 20%, delivered between 15 to 20 grams of glucose. I don't think there's anything else in this question, so that was that. We go back to, was it this one, Gina? Was it this one or the one before?
Yes, so it was when you were doing adjustments to their background, but not their breakthrough.
Oh, the reason? I'm not exactly sure what the reason is. I just know you do not change the breakthrough. So when a patient needs an increase in their morphine, so if they're still complaining of pain, the background the background dose of morphine instead of the breakthrough is adjusted. And the reason to go with 25, again, you're limited with what dose you have available. So you have to pick a dose that will increase the morphine dose, but no more than 30%. So, and whether modified release is oral or not, I think it's because the question, I didn't write this question myself. I took it from one of the previous presentations, but it's probably because it's not written. But in the exam, it guaranteed it must specify if it's IV or oral. But I do agree with the point that Charlotte has mentioned with regards to the route of administration. So hopefully that's clear. If it's not, I'm happy to come back to it later. Okay, one more fluid. I think this is the last fluid question. So this is a PEDS fluids question. So make sure you switch the BNF section to PEDS. And we'll say another minute. Okay, 6-year-old presenting to the emergency department with severe diarrhea, vomiting, unable to tolerate any oral fluids. So she's not had fluid. She's not had fluids for past 12 hours, and diuretic and vomiting. So a lot of fluids, a lot of electrolytes lost there. Tachy and hypotensive, with delayed capillary fill and dry mucous membranes. You look at her electrolytes. Sodium's normal, potassium's low, urea is high, and creatinine is normal, and her blood glucose is fine, and it's asked you to prescribe an IV fluid. So with fluids, as we will go through in just a second, there are different categories of different fluid IV solutions that you can prescribe. So it's important from the vignette or the question to figure out which type of solution and why you're giving it. So is it to maintain fluid or is it to resuscitate? And hopefully you've spotted from the picture and the vitals that this is a resuscitative solution. Different options, multiple different options available to prescribe, as long as you take into account the patient's weight and the fact that they've got deranged electrolytes, and prescribe an appropriate solution containing both the fluid component and the electrolytes. Hopefully you should arrive at the correct answer. So Hartmann's, plasma ringers solution, and sodium chloride with the different doses. Okay, so this is what I was talking about. It's important to tell which is which and like what exact solution you need. So for emergency resuscitation, it's normally saline 0.9%, 500 milliliters over 10 minutes. Hyperkalemia. Again, I think in our question, the potassium was low, wasn't it? Yeah. So important to take that into account. Hypercalcemia also require a different solution, a different volume and a different time as well. And hypoglycemia obviously is glucose. We went through an example of that. And then you have your maintenance fluids. So patients with probably like a normal blood pressure, maybe a bit tachy, but maybe vomited or post-op and require a bit of adjustments to their like electrolytes, and they may be milder than your resuscitative emergency presentation. In that case, you would replace the required amount of electrolytes in the body, which is 25 to 30 milliliters per kilogram. Again, calculate using the patient's weight over 24 hours. And then for glucose, that's for sodium and potassium. For glucose, it's 50 to 100 grams per 24 hours. Yeah. Okay, so this is like a wrap up for drug calculations. These are the different sections we went through, but just stuff to keep in mind in case you've identified like a weak point. And the best way is just to do lots of questions. Just tackle the questions. Make sure you know how to navigate the BNF for the opioid conversions. Dosing by weight we went through. Dosing by body surface area. For peds patients, you don't need to calculate using an equation. For adults, I think you do. I'm not sure if I added a slide for that or not, but I'll go through that towards the end. I'm hoping that there's a slide for that. But there's a certain equation which for BSA you'll need to sort of plug in the patient's weight to calculate. And then fluids and antibiotics and steroid weaning are. I've also got a slide for steroid weaning, but these are the different sections just to keep in mind. Okay, prescribing.
Oh, just before we move on from calculation skills, there's just a couple of people asking similar questions to me in the chat. So, first one was regarding opioid background dose increases. Yes, you can increase by 33 to 50% according to current guidelines. Then, on top of that, in terms of fluid prescribing, yes, you do different formulas for children versus adults. In adults, we have the set algorithms, and you can do resus or you can do maintenance fluids. That's algorithms 3 and 4. In children, you do by body weight, and you do cumulative when it goes past 10, and then I think 19, and then above 20 kilos. I will refresh. But if you guys are struggling with calculation skills, we have a recording in the chat. Go for it.
Peds volume.
Yeah, so
I've got another question on that.
yeah, we've got another one later, but anyone struggling with calculations, Bethan did both the calculation skills and pediatric sessions where she goes through how to calculate for BSA on children and also goes through different fluid prescribing in children. So thank you for clarifying in the chat, guys. I will link those videos as well.
By the way, this was from the calculation slides. So 30 to 35%, I guess it is. But yeah, it's important to clarify to everyone. So you can apparently. Okay, let's go through some prescribing questions now. Okay, here's the first one, geriatrics presentation. And you're asked to prescribe one drug, which is most appropriate for treating the cause of their sore mouth. Hopefully not something you're not expecting. A very typical presentation there. Okay, hopefully very typical presentation. Patients taking inhaling steroids and yeah, is it white plaques? It says white plaques that are removable on scrubbing is very typical of an oral pharyngeal infection. So that's the section which it's always the treatment summary, the first thing that you go after to get to the condition and the drug and the appropriate dose that you want. So you'll be after the oral pharyngeal fungal infection section, and then under that, hopefully you'll find the appropriate dose of nystatin to prescribe. And yeah, I've just got a point there below. Sometimes in some questions, a typical presentation like this one, and you're sort of stuck in between two options. It's always useful to look back at the different drugs and medications that the patient's taken. And sometimes a clue that could be that one of the drugs or the medications that you're stuck in between would interact with a medication that the patient's already taken. So that could skew you towards the other option. So always keep an eye out on the different medications that the patient is taking. So in this example in particular, it was meconazole would be one of the options because it's used to treat all fungal infections, but then the patient's already taken warfarin, so it would interact with their warfarin. So just keep that in mind for the easy prescribing questions. Okay, another prescribing question. This time it's women's health, OBGYN. And you're asked to prescribe one drug that is most appropriate at this stage. Okay, 55-year-old presenting to GP to review current hormone replacement therapy. So menopause, she's already presenting menopausal flushes, last period 2 years ago. She's taken estradiol patches and estradiol with northisterone transdermal patch, weighs 68 kilograms, blood pressure is normal, and she asks for an alternative hormone replacement therapy, specifically to avoid withdrawal bleeds, and would prefer a transdermal patch. So again, treatment summaries, gynae, and I guess it's picking the appropriate hormone replacement therapy for the patient. So again, just recapping gynae, if the patient's got a uterus and has not had their uterus removed, progesterone needs to be added to estrogen to prevent, obviously, patients continuously taking estrogen, there'd be a risk of endometrial hyperplasia. So the progesterone would account for that. And then the second step would be deciding between cyclical or continuous. That would depend on when their last menstrual period was. And if it's more than 2 months, then she could take continuous patch. So two steps to hormone replacement therapy. Does the patient have a uterus? Is it cyclical or continuous? And then any other patient considerations like withdrawal bleeds as would be in this patient. So it's for this patient, because they've asked for that, you'd give estrogen and progesterone transdermal patch, 150 micrograms per 24 hours. Okay, a shorter question this time. And I think this one is surgery. So this is post-op surgery, one medication, one drug most appropriate for venous thromboembolism prophylaxis in this patient. Is the chat alive, Charlotte?
The chat is alive. And guys, thank you so much for raising any queries and points. I'm trying to get through all your questions. And for any ones that require a longer answer, I'm trying to link the previous session where they've been into it a lot. So we've just had someone ask about the HRT question. Doses of the patch, Catherine goes through in a lot of depth as well. They're usually quite standardized and set, and it depends on peri versus menopausal. And she's created a full summary, so you can just go to that timestamp, which I'll find, and it goes through like Everol Sequi versus Everol Conti and different formulations you can get. So hopefully that helps. If it doesn't though, please do just say, and I can find another resource for you.
So that's a minute. 54-year-old man presenting after an elective total hip replacement 12 hours ago. So taking paracetamol, dihydrocodone, 4 hours as required. They've given you the patient's weight. Hasn't got any electrolyte abnormalities, and then just asking to prescribe the appropriate medication for VT prophylaxis, which would be heparin, dalteparin. I can't. Let me see the answer, guys. I'm sorry, I can't see the answers. So I don't know if you've answered correctly or not. But can you tell, Charlotte?
So I can't tell. I think people put their answers down and then they can see.
Okay, sure. Any concerns? Drop a question. Hopefully we can come back to them at the end. Okay. So prescribing, guide to prescribing, uh, treatment summaries. So that's the first step. Figure out what sort of area of the BNF you'll need to be looking at. So the first question, the oral fungal, would be fungal infections. HRT would be somewhere in gynae, and then the surgery, VT thrombo prophylaxis would be in that section. The second thing, straightforward, easy, typical presentations. Make sure that the drug you end up picking doesn't interact and doesn't cause any side effects, just like the meconazole with the warfarin. So you want to avoid that. You want to also check bloods, past medical history. You don't want to give beta blocker to a patient who has a past medical history for asthma. And then finally, get the dose, the route, and the frequency correct. Okay. Yeah, so this slide was taken from the surgery presentation surgery lecture. The slides are there. Just spam Charlotte on WhatsApp. Send her lots of questions and ask her to send you the slides, and hopefully she'll send them to you, won't you? Oh.
How dare you?
Okay,
Can
so this is
spam the MedEd inbox. Our secretary is brilliant.
Text her every day. She'll send you the slides. So I like op. Very nice mnemonic to remember. Drugs to stop before surgery, insulin, lithium anticoagulants, oral contraceptives, potassium-sparing diuretics, hyperglycemics, and ACE inhibitors. And then the table also at the bottom there also nicely tells you which and when to stop accordingly. Peri-op, so just considerations. This is the point that I touched on in the drugs calculation summary slide. Steroid cover. So you'll need to consider that when a patient has been taking a steroid for more than 4 weeks, and for a dose that's equal to or greater than 5 milligrams, or any high recent steroid use. Cushing going appearance, okay, maybe, but I think the timing and the dose are more important for that. And the idea again is to avoid adrenal crisis once you stop them if they go into surgery. And then other glucose considerations, minor or local anesthesia procedures. So no, not major surgery would be to continue their usual dose. You don't change them. And then if it's moderate to major surgery, you would need to give IV hydrocortisone, 100 milligrams at the induction, and then double the usual steroid dose for the subsequent 24 to 48 hours, and then slowly taper them down afterwards. Post-op, we have discussed the fluid maintenance needs. So in adults, 25 to 30 milliliters per kilogram per day. And then if they've got heart failure or some sort of renal impairment or renal failure, this would be taken a notch down to 20 to 25. In children, this is, I think, yeah, this is the point you were talking about, Charlotte. So for the first 10 kilograms of weight, it's 100 milliliters. For the second 10, the subsequent 10, it's 50, and then 20 or more for every kilogram, it's 20. You'll see a lot of these questions in practice tests. So just do a lot of calculations, and hopefully you'll be set. Hormone replacement therapy, touched on this, but this is again from the women's health session that was done earlier this year, I think. So hormone replacement therapy, no uterus, you only give estrogen because there's no risk of endometrial hyperplasia. If they do, then you need progesterone to for protection. If their last menstrual period was in less than 12 months, they need to be cyclical, so they need to mirror the menstrual cycle. If it's longer, then you can happy to go on continuous. And then these are the different forms that it can be prescribed in. Again, just do lots of questions. If anyone wants to add any point or still unsure, just drop a message or drop a question. Contraception. The most important thing here is contraindications to combined oral contraceptives. So BMI 35 or more, smoking, patients 35 or older, hypertension, previous history of stroke or cardiovascular disease, and multiple risk factors. Cardiovascular, that's kind of the same thing. But your typical cardiovascular, high cholesterol, diabetic, with maybe like a previous MI, you would think about oral contraceptives just because it would increase the risk of VTE. Other considerations with combined oral contraceptives is cytochrome P450 inducing drugs would interact with the prescribed contraceptive. So you'd need to either adjust the dose of the contraceptive or consider a different medication that doesn't interact with the liver enzymes. Okay. Patient drug calculations. Remember to switch to pediatrics when prescribing medications. First type of questions you might get is the simple dose by weight. The second, resuscitation. So remember, it's 0.9% saline, 10 milliliters per kilogram, and it's in 10 minutes. Maintenance. This is the point we were discussing several times. 100 milliliters first 10, 50 subsequent 10, and then 20 or more would be 20 per kilogram. In diabetics specifically, you would in fluid deficit, the equation to calculate fluid deficit. I don't think there's a question on that, but I did see a few. So to calculate fluid deficits, you'd need to add first calculate what the fluid deficit is, add that to maintenance fluid, and the equation for that would be the percentage dehydration. It would be given to you in the question, multiplied, or you'd need to calculate it based on the change in weight. So the original weight minus the new weight divided by the original weight would be the fraction. Very simple, nothing crazy. Very, very simple. And you'll be given the previous weight and the weight, so the drop in the weight after the patient has gone through dehydration. You'd multiply that by the patient's weight by 10. And I think it's the original weight. Correct me if I'm wrong. A few points of prescribing specifically for psychiatry medications. So I guess you can go through these. Nothing maybe I could add, but yeah, just make sure that for lithium, lamotrigine, valproate, and antipsychotics, for each respective medication you prescribe, if there's any specific consideration. So for lithium, the blood checks. For lamotrigine, it's the risk of the skin reaction. Valproate, tetragenic, and antipsychotics is mainly the side effect in different antipsychotics, which varies depending on the antipsychotic you're prescribing. For antidepressants, it's the same thing really here. For SSRIs, I guess this is important in counseling, but you want to make sure you address the points regarding suicide on initiation, the increased risk. Venlafaxine, duloxetine have several other indications. I don't think there's anything else, but make sure you know how to get to these different medications from the treatment summaries, and to know which medication to prescribe in depression, anxiety, etc., etc. Okay, several tips. Again, another slide taken from a previous presentation. Hopefully, you know some of these by now. We've been practicing using the website version of the BNF, but these are some tips on how to quickly get to different medications through the appendix. Okay. Some more tips. Nothing that we've not mentioned yet. BNF treatment summaries, appendix. How to get to the appendix quickly is written here. So Control C and Control V Split screen, I guess, is the questions and the BNF. Yeah, nothing else. So we'll just move on to prescription review. So, and we'll have a go at this question. I'll give you guys a minute. It's 2 parts, so maybe like just over a minute. And yeah, we'll keep going afterwards. Okay, 74-year-old female presenting to the GP for a medication review. So elderly care, polypharmacy, lots of medications, drug interactions. Just keep that at the back of your mind. Has a past medical history: depression, reflux, hay fever, hypercholesteremia, hypertension, type 2 diabetes, urinary frequency and incontinence. And a lot of these conditions and medications it's just a pattern. It's just a pattern. The more you do questions, I guess, on PassMed for your AKT, the more you'll be able to pick up these patterns. I mean, some of these medications you can just spot before even pulling up the VNF, but do open up the VNF and check before you. But I guess if you're restricted with time, which I think is an important thing in the exam, that's an important thing to think about. So first part of the question is selecting the drugs that increase the risk of cognitive impairment. And the second is a drug that or a medication that is not indicated for that patient. Okay. So the first three of that increase the risk of cognitive impairment, chlorphenamine, which is an histamine medication, oxybutynin and chlorphenamine, sorry, is it anticholinergic? No, antihistamine, I was right. It's a sedative antihistamine. That's why it's not prescribed in elderly patients. Oxybutynin hydrochloride, anticholinergic, so parasympathetic, increases risk of sedation and falls. And paroxetine is a SSRI, but it also has anticholinergic properties to its mechanism of action. So similar to oxybutynin, parasympathetic, increased risk of sedation and falls. So that's that for those. Try to, whenever you see these medications in a prescription review question, elderly patient with the same profile, just to think of these different considerations in the back of your mind. So sedation here is the main sort of theme, if you like. And the second was aspirin. And the idea here is it's not indicated just based off the patient's history. So if you look back, depression, GORD, hay fever, hypercholesteremia, and hypertension, and type 2 diabetes are not enough to sort of satisfy for an indication to prescribe aspirin. Is the case, I think, here. Okay. Some general tips, medical emergencies in the community section on the BNF. Again, it's your treatment summaries to get to that. So the different presentations you can get, poisoning, epilepsy, Again, if you go through these different sections, you'll see the different medication options. For antiemetics, if vomiting in the patient's history is mentioned, it's important to consider switching the route that you're prescribing your medication in. Elderly patients with a past history of heart failure or any symptoms of fluid overload, just consider tweaking the fluid volume for emergency fluid resuscitation. So it's not 500, it's 250. Other tips, neuropathic pain. I'm guessing hopefully you've seen these medications by now. Migraines, similar thing, just keep in mind whether it's with aura in the presentation or without. And antiemetic options depending on the indication. So if it's vertigo, if it's post-op chemotherapy, if it's palliative or Parkinson's, the medication will change. How do you know? Well, maybe you know because you've done a lot of questions. If not, treatment summaries. Nothing else to say here. Okay, some other tips. Well, sorry. For the prescription review, checking the dose, the timing, the formulation. Falls is similar to what we talked about in sedation. Benzodiazepines, antihyperdepressants, psychotics, opioids in your elderly patients is what to think about. Constipation, again, these are the 4 medications that frequently cause constipation. So you want to think about maybe stopping them in a prescription review. Opioids, iron, calcium channel blockers, antiserotonin, and anticholinergics. Okay. Yep, and interaction checker. Hopefully you've used the interactions checker. Put the different medications in, and you'll be able to tell which ones need stopping or not. Okay. Guide to prescription review, Appendix 1, Control F. I think I've already mentioned that. But practice using the keyboard to reach the appendix and to also use the interactions checker. Other than that, checking the dose, checking the timing and the frequency is all you need to know. Just do a bunch of questions. There's nothing else you need to know. As I said, some of them you'll know, some of these drugs, some of the different patterns, prolonging QT, hypertensive, sedation, some of them you'd have known already. If not, just to do a lot of questions, do a lot of practice questions. That's all you need to know. Okay. Counseling. I think it's just one question counseling. The options are on the right, by the way, in black. And they have asked you to select the most important information option that should be provided to the patient. We'll say a minute and we'll catch up after. Okay, 48-year-old woman presenting post gastric bypass surgery for severe obesity. She has a past medical history of obesity, depression, migraine, taken an NSAID and SSRI. So post surgery, she's advised to add some medications, so iron, calcium, and B12 as a result of obviously the absorption considerations to make, or specifically the stomach considerations to make, like B12 and intrinsic factor, which will not be available. So first option is calcium and iron preparations should not be taken on the same day. Escitalopram dose should be increased due to reduced absorption. Hemoglobin checked monthly to ensure it's compliant with iron therapy. NSAID contraindicated following bypass, or iron products are best absorbed when taken with food. Again, I cannot see the comments, but hopefully you've selected the first one because they interact with each other, and calcium reduces the absorption of iron. So that's the counseling point to mention here. And to separate the doses between the two. So not to take the two at the same time. So it's 1 hour before or 2 hours after taking iron that the patient should take their calcium or calcium-containing food. Other calcium points. So metformin, very commonly prescribed medication. You want to think about the renal function and the risk of lactic acidosis, and just to counsel them on that. Digoxin, electrolytes, hyperkalemia specifically, because potassium and digoxin, they sort of compete on the same receptor in the heart. So in the AV node, the sodium-potassium pump that they both compete at. So in an AKT question, PassMed, a typical digoxin overdose or toxicity patient would be hypokalemic. If a patient's hyperkalemic, then the dose of their digoxin will need to be changed, for example. Or if they're taking a medication that causes hyperkalemia, you need to be counseling them on the or thinking about the risk of digoxin toxicity. So that's the point there. SGL2 inhibitors, you want to think about DKA, symptoms of DKA, counsel patients on DKA symptoms. Methotrexate, the one you hopefully all know, is myelosuppression. So checking tests, running tests frequently, and counseling the patient on the symptoms to look out for. Unsafe drugs in pregnancy, NSAIDs, they decrease prostaglandins. Prostaglandins in babies born with duct-dependent lesions. So lesions cyanotic lesions that depend on the PDA for the fetus or the baby, to stay alive, require prostaglandin in the mother's womb. So the placenta produces prostaglandin. If the mother takes NSAID, that reduces prostaglandin, the shunt shuts, and the baby goes cyanotic, and they might actually die. And by the way, after birth, they continue taking prostaglandin until they go stage palliation surgery. ACE inhibitors, it's the kidney issues that we're worried about. Angiotensin 2 receptor blockers affect the kidney function, which affects during pregnancy the production of amniotic fluid, and that's why it causes oligohydramnios. Retinoid complications, multiple different complications, like a syndrome of different symptoms. So stay off that. And warfarin is bleeding. So hopefully you would have guessed that. So keep these in mind. If you see them, pregnancy, stop. Some more medications to stop in pregnancy. Each one has a different reason, but they're all teratogenic and they need to be stopped. Specifically, it's the weeks in embryogenesis where the different organs form, which are 4 to 10. 4 is where the first, which is the heart, forms, and then it's all the way up to 10. This is the first trimester, technically, which you need to be most worried about. I think we've already touched on some of these. Psychiatry is medications. If you're going to revise one thing in psychiatry, it's the medications and the counseling points and the different side effects of each medication. So suicidal ideation when you start sertraline. There are a few ones like hyponatremia and reduced libido, but the main one is suicide ideation. Olanzapine and antipsychotics, the different anticholinergic effects you need to think about. Zopiclone in an elderly patient, you would also need to be cautious and worried about the risk of sedation. Data interpretation, very busy slide. The question is on the top left. The patient's INR results are on the bottom right, and the options are on the top right. So let's say another minute, and we'll come back. Okay, I've extended a bit of time because I do appreciate it's a busy slide, but don't let that sort of distract you. It's the idea is very straightforward here. 69-year-old presents GP INR check. Something will be wrong with the INR, and it's most commonly patients undergone heart valve surgery and inserted a mechanical valve, taken warfarin with a few other medications, uh, bisoprolol, clarithromycin, and then their target INR is 2.5 to 3.5 for heart valve replacement. And as you can see, an important point to mention in the drug history is wait, did he complete the course? Oh, okay, that's fine. Anyway, the question asks you to select the most appropriate decision option with regards to their warfarin based on the data. So I guess that's the chart. So if you see the first 3 weeks, they sort of their INR is between 2.6 and 3.4, but then in week 4 it jumps to 6.7. If you plug in their the different drugs that they take, you hopefully spot what's going on here. So you stop warfarin and recheck INR is the answer. So let's go through why that is. So hopefully if you check the indications, you'll see that macrolides, they inhibit cytochrome P450. Medications that inhibit cytochrome P450 will prolong the action of drugs that are metabolized in the liver by cytochrome P450. So to put that in other words, basically, warfarin is metabolized in the liver by cytochrome P450. If you take a medication that inhibits this enzyme that breaks down warfarin, there'll be more warfarin around. And that's why the INR suddenly became prolonged, because they've started clarithromycin. So in the 4th week is when they started clarithromycin. It jumped from 3.4 to 6.7. And that's important because it's above the threshold, and it increases the risk of bleeding. So the next advised action is to withhold 1 or 2 doses and then reduce the subsequent maintenance dose. It gets a bit technical with warfarin and INR, and if patients present with major hemorrhagic bleeds and they're on warfarin, when do you stop INR? When do you prescribe vitamin K? Try to find the guidelines. There's a set of guidelines which sometimes I remember, sometimes I forget, but make sure you know what to do if a patient's with the different scenarios, basically. I think it's also on PassMed, but have a look at the BNF for the PSA. Adverse drug reactions. Yep, okay, another minute. And you are asked to select the prescription that is most likely to interact with indapamide. So you should know what to do, hopefully.
For anybody that needs to leave, I'm trying to put the feedback form in the chat at intervals because it's just really helpful to hear from you guys how you're finding these sessions. We've never done it before. It's not perfect yet, but hopefully it's helped lots of people, and you don't have to pay silly money to pass an exam, which is a national requirement. So any and all feedback is great, and then we can make it as good as possible for future students as well.
Okay, 48-year-old man presenting vomiting, polyuria, thirst, tremor, muscle weakness, and confusion. So you don't even need the vignettes. The question's very clear at the bottom. Just the drug that is most likely to interact with indapamide. So you can find that on the BNF, be lithium, and it's the change in levels of potassium, which will or sodium, sorry, the absorption of sodium. So basically, indapamide and thiazide diuretics act in the same way. So they promote the excretion of sodium, and then that encourages the reabsorption of sodium in the proximal convoluted tubule. And lithium and sodium get reabsorbed together. So if you take a drug that will encourage or increase the reabsorption of sodium, A good way to think about it is they're transported sort of together in the same mechanism, so that will increase the levels of lithium, and that's why the two interact together and should be stopped. So that's why it's lithium within diethylamide. Touched on a few of these. So bipolar medications, SSRIs, and antipsychotics. Make sure you know the common side effects for counseling, for prescription review, and for dosing as well, and for interactions. Very busy slide. Takeaway points. Any drugs or drugs that interact with other drugs when taken or combined oral contraceptive pills, the main risk you'd be thinking about is the risk of thromboembolism, stroke, and MI. That's why there's a set of contraindications where you'd not get prescribed a combined oral contraceptive and would instead give a progesterone prescription as contraception. HRT would be the different forms and the risk of breast cancer in each after a year of use. So keep these in mind. We've also touched on a few of these. So we discussed hepatic enzyme induction and inhibition. When we touched on it when we talked about warfarin, combined oral contraceptive pills. It's the same ideas. Drugs that induce the enzyme, cytochrome P450, you'd need a higher dose. Basically, that would decrease the effect of the drug that you're giving. Drugs that inhibit cytochrome P450 would mean that you'll have more of the drug around because it's not metabolized, and you'll need to adjust the dose of the drug, or if it's going to cause like a major side effect, like a bleed, in the case of warfarin, you'd need to stop it. Finally, drug monitoring. We're near the end, I promise. Have a look at the chart, have a look at the question, and we'll go through it afterwards. Okay,
Popped a
so
message for when people are done as well.
they're done.
No one's liked it, so I'm just going to assume people are silently in the background. Yeah, they're all liking it now. Sorry guys, I know the chat's very busy today.
Gentamicin with a few other medications, they have a narrow therapeutic window. So the dose at which the drug starts working and the dose at which it starts becoming toxic are very close. It's the window in between is very close. So these drugs require a lot of monitoring, and this is one of them. So surgical patient, pyelonephritis, presenting with back pain, prescribed codeine, paracetamol, and gentamicin. You've got their labs, their urine's high and creatinine's high, and they've got a low EGFR, secondary to their history of pyelonephritis. The serum gentamicin dose taken, the serum gentamicin levels taken 8 hours after their last dose is 3 milligrams. You've got the chart at the bottom. So after 8 hours, they've taken 3, I don't know, where's my pointer? Laser pointer. 8 hours post last dose, 3 milligrams, puts them in the 24 hours dosing interval category for serum gentamicin, and then that would determine what you do next. So that's what the question is asking. the most appropriate decision based on the level. So it looks very fancy and some stuff going on, but it's very straightforward. You'd prescribe 5 milligrams of gentamicin per kilogram IV. And the reasoning is in the screenshot I put. So it's you'd use a nomogram to check that they're at the level you're expecting. And basically, if the resultant point post last dose and post last measurement and the dose of the level of gentamicin in that timing is within the 24-hour area, then you'd continue the same dose, which is in our case. If it falls above, then you change depending on if it's in the 36 or the 48 or higher. If it's in the 36 hour area, shaded area, then you change to 36-hour dosing, 36 hourly dosing. 48 would be 48. And then it says, I took this, by the way, from the book, the PSA book. If the point is above 48, then you'd repeat the measurement of gentamicin and only redose when the concentration is less than 1 milligrams per liter. So it's just it tells you how frequently to prescribe gentamicin because of the narrow therapeutic window. Okay, I think this is the last one. I promise, hopefully. Inshallah, this is the last one. Planning management. Very short, so we'll say like just less than a minute, and we'll go through it afterwards.
Please do like the message in the chat when you're done, guys.
They'll be done very quick with this one. Hopefully. Okay, 25-year-old female presenting obstetrics clinic, 28 weeks, no symptoms, high fasting glucose, no fetal abnormalities, diagnosed gestational diabetes, most appropriate management step. This is a guidelines question, nothing to explain, just lifestyle. And I think it's also on PassMed as well. But you should find it on the what's it called, the BNF. So treatment summary for diabetes, pregnancy, and breastfeeding, and then below gestational diabetes, there should be a paragraph in there that says that the first thing you should do is change diet and lifestyle when the plasma glucose level is less than 7 at diagnosis. But if it's higher, then you would start on glycemic medication. I wasn't expecting another question. I'm sorry.
You made these slides, bro.
Yeah. Well, I made them a few days. I'm on a busy surgical rotation now. I made them a few days back because
That's
someone
so
asked me
funny.
to send it to them. Someone asked me to send it to them on Sunday. Someone. We don't know who that is.
Who would
Should we
do
go
that?
through it? Are we running over time? Should we go through it or not?
No, it's fine. I advertise this as a longer session because it's
Oh,
literally 9 weeks in one. So you're doing great. You're actually really on time.
okay. Let's go through it. Okay. Give you another minute and then we'll discuss. Okay. 75-year-old gentleman presenting into the emergency department, increased breathlessness on exertion and palpitations, which is acute onset. Very cardiovascular, past medical history. They've had a previous PCI inserted, on clopidogrel, amlodipine, bisoprolol, and a statin. They've got irregular rhythm. They're tachycardic, no evidence of heart failure, and their labs show high urea creatinine. Their eGFR is low. ECG gives you the diagnosis atrial flutter with ventricular rate of 150 beats per minute, which is very high. Clopidogrel stopped, and apixaban was started instead for the risk of clotting and thromboembolism. Options: add an additional dose of beta blocker, amiodarone, digoxin, flecainide, or DC cardioversion. BNF. What does the BNF say? That's what you go with for atrial flutter. And the idea here is, why is my pointer? The idea here is increased heart rate will reduce ventricular filling in a patient's already with a past medical history of needing a PCI and a weak ventricle. So you need to slow down their heart rate in order to support ventricular filling and cardiac output. So beta blocker, slow down the heart rate, and that's why it's the next best thing to do, the medication. These are some of the different conditions. Make sure you know how to get to the treatment summary subsection for the different conditions. So you want to figure out what's going on. You want to make sure you know which tab on the treatment summary to pick, and then scroll until you find the condition that you're after. We've discussed, I think we've discussed some of these. You'll get the slides. You can look through these hopefully in your own time. Yep, somewhat the same. Important considerations in pregnancy, diabetes in pregnancy, and hypertension, preeclampsia. This table just shows you what is the first and second line medications for diabetes in pregnancy and hypertension and preeclampsia. The end. Finally. Thank you all for joining. I'm sorry I couldn't see. Is that there was a bit of a communication barrier. I couldn't see the comments. It's not like Zoom. Again, someone chose to switch from Zoom to Microsoft. I'm against I'm against Microsoft. I'm pro Zoom because
Right.
I at least
It's
I can at
better.
least see the comments. Well, you're entitled to an opinion, but at least I can see the comments was when.
Yeah, I've been goated in this chat though, apparently. So I'm having none of it.
I didn't see that, so it didn't
Well,
happen.
it's there. For people who can't see this chat once it's recorded.
I mean, you did a great job with just sending the different comments and informing me about them. So thank you for that.
Thank you everyone for coming.
Yeah, thank you. Sorry it was long, slow. Any sort of drawbacks from my side, I do apologize. There are a few slides from previous sessions. If there's a specific chapter or a specific skill you're unsure about, go back to the session slides and have a look at them. Yeah. And good luck with the exam. Just try to practice as much as possible. If you need help, if you want the slides, if you have any issues, anything in your life, spam Charlotte. She'll help you on the.
I'm about to block your number. It's been many good years.
And it's ending that way, huh?
Mm-hmm. This is how it ends. I think you've got someone asking you to go back a couple of slides.